Join us this evening as we host one of our viewers' favorite shows, Ask Anything. Tonight's show focuses on all medical topics affecting those in our viewing audience. Ask Anything, tonight, on Call with the Prairie Doc. Major funding for On Call with the Prairie Doc has been provided by
Good evening, and welcome to On Call with the Prairie Doc. I'm Dr. Debra Johnston, your volunteer Prairie Doc for this evening's program. Tonight, it's one of my personal favorites, and our viewers' favorites too. It's Ask Anything. You can call in with any question about any medical topic, and we'll try to answer it. In the studio this evening are Dr. Jennifer Tinguely, the Chief Medical Officer from Falls Community Health, and Dr. Makayla Bretschneider from Sanford Watertown Clinic. Thank you both for being here with us tonight. Jen, tell us a little bit about yourself and what made you decide to be a family doctor.
Yes, I'm Jen Tinguely. I'll just start. I'm married to a philosophy professor who teaches down at USD. I have two kids. I have a 15-year-old daughter and a 13-year-old son. So, mom. And then, I'm a family practice doc. I work at a community health center in Sioux Falls, South Dakota, and I have been there for 12 years and just so happy to be in that field, in this profession. I have a passion for public health, so working within the City of Sioux Falls Health Department is where we're housed, and so I get to touch a little bit of that, but then just take care of patients and do our best for primary care.
And you do a lot of addiction medicine too, do I understand that correctly?
Yes, I do. For the last 8 years or so, I just took an interest in providing medicine and care for patients that are struggling with substances. So that's been kind of where my area of focus has led me in this family medicine adventure, but yeah.
Wonderful, such an important field.
Yeah.
Makayla, tell us about you and how you ended up in family medicine.
Yeah, so I'm Makayla Bretschneider. I'm currently practicing in Watertown, and I'm newer to practice. I'm about 2.5 months into practice. So I'm married as well. My husband is very non-medical. He works in kind of more manufacturing industry. We have a 2-year-old son. And I think for me, like, rural medicine is kind of how I got to family medicine. I'm from a small town, and just seeing the variety of care that family medicine physicians can provide, and then also just the longevity or the relationships that they're able to form with their patients, I think, is what really drew me to family medicine.
It's a great field.
Mm-hmm. Yeah.
Before we jump into our discussion, I'd like to take a moment to express my gratitude to all of our viewers. As a volunteer Prairie Doc, your contributions each week are invaluable. Every dollar you give helps us produce meaningful content that empowers individuals to make informed health decisions. And now let's turn our focus to you, our audience. We invite you to submit your questions for tonight's conversation on any medical topic. There are 3 ways to reach us. Call us at 1-888-376-6225. Send an email to ask@prairiedoc.org or engage with us on our Prairie Doc Facebook page. We will do our best to address as many of your questions as time allows. If we can't get to yours, we sincerely apologize. All of your questions are anonymous and no information will be saved. However, if you would like to leave your name, email, or phone number, you'll be entered into a drawing for our Prairie Doc publication, Perspectives from the Prairie. It's not a requirement to submit a question, though. We'll announce the winner at the end of the program. I'm sure we're going to get lots of questions, guys, and I'm looking forward to it. We were talking beforehand, and I was telling these ladies that sometimes it's fun to see if they can play Stump the Prairie Doc and to come up with questions that, as we do in the clinic every day, we say, I'm not really sure, but let's figure out how to approach this and problem solve this question. So that's okay. So. We are going to have some questions here. We have one already from email. This individual says that her husband has blood cells in his urine, had that a couple years ago, and now he was diagnosed with diabetes. He's 31 years old. A doctor once told him to drink cranberry juice and that would help him with the blood in his urine. Is that helpful advice? Now that he has diabetes, she's concerned that it could lead to something else related with his bladder. Makayla, what advice do you have to, we've kind of got two issues here, don't we? We've got the issue of the blood in the urine and cranberry juice, and then the issue of the diabetes. What would you say to this person worried about their spouse?
So I think as far as blood in the urine, the cranberry juice I think is more helpful for like urinary tract infections. Is typically more commonly where blood in the urine doesn't necessarily mean an infection.
It could. It doesn't necessarily.
Depending on what other things are present in the urine. If it's just blood, I think that maybe would require more workup potentially to see if there's something like cystoscopy, like a urologist, to kind of work that up a little bit more to see where that's coming from. And I think as far as diabetes, I mean, we know that can lead to other health complications, right? So like neuropathy, eye concerns, kidney concerns, cardiovascular disease. So really making sure if they have a primary care doc that can kind of help them navigate that and provide that comprehensive care for them.
What would you add, Jen?
I mean, I would say one thing too is knowing that this gentleman now has diabetes. I would try and shy away from too much cranberry juice, high in sugar, probably going in the wrong direction in terms of bringing those sugars down. But I would definitely worry about, is the blood indicative of something going on? Like you said, in the bladder, is there a tumor or something that might be causing that, or is it higher up in the kidneys? And so now knowing that there could potentially be something in the kidneys, the diabetes, that makes that even riskier. Just definitely want to encourage that gentleman to make sure sugars get under control, that blood pressure is well controlled, anything to keep those kidneys as safe and healthy as possible.
Yeah, and if they didn't have more of a workup, and some of it depends too, was it red blood cells, was it a lot of blood, was it a trace blood on the dipstick? That all kind of guides how anxious we as physicians get about that. So it'd be something worth asking whoever their current clinician is, hey, do I need to do anything more about this blood we find? Do I still have blood? Do I need to see a urologist to look at my bladder? Do I need an ultrasound to look at my kidneys? This is definitely someone who needs a primary care doctor.
That's right.
Absolutely. We have a question from Facebook. This individual has had total knee replacement and will be having a liver biopsy. Should they be taking an antibiotic prior to the procedure like they do when they have a dental appointment? Jen, what are your thoughts on that?
So I actually think that the antibiotic before dental procedures is something that we've been trying to move away from. There's very few people that actually need to have an antibiotic before a dental procedure. So not knowing kind of the reason behind it, I would say, likely not necessary. Obviously working with the surgeon, and then usually there is some pre-operative clearance that has to come from a usually primary care provider. Knowing, is there a reason why you would want an antibiotic on board? Probably not necessary, would be my guess.
Yeah, I would agree with that. I feel like that's definitely been a kind of a transition, is less of like that pre-op antibiotic, especially with the liver biopsy. I think depending on the situation, that can be fairly like not super invasive. So I would say probably not necessary. And I think one thing too is there's always like side effects or risk with antibiotics too. I mean, like the GI upset. I mean, there's just other things that can happen with it. So if we don't need it, probably better to hold off.
I think especially a liver biopsy, dental issues, invasive dental issues, the mouth is a very bacteria intense area, whereas if you're doing a liver biopsy, they can sterilize that area before they puncture the skin, so that's probably not necessary. I know a lot of the orthopedic surgeons are very anxious, and having had a few patients who have had prosthetic infections and watched the horror that they went through trying to get that cleared up, I get it. I get why they're anxious about that, but statistically it's so All right. This individual says, I have an upper GI appointment to determine why I feel full so quickly when eating. I currently have a virus, not COVID or strep or mono. Should I do the procedure or put it off until the virus is gone? I currently don't have any pain and am not losing weight. I am immunocompromised. That's a a lot going on for that poor person.
Yeah.
Jen, what are your thoughts there?
I would say wait. Let your body heal up and then move ahead with the procedure. No need to increase risk of further infection. I mean, if somebody's immunocompromised already and then fighting off some sort of virus illness, I just think the body's already stressed enough. I think if the endoscopy, the EGD can wait, I would say just wait.
I think lots of times if you do have a viral illness and you do anesthesia, lots of times they don't like to just because it can increase the risks of having complications with those procedures in the anesthesia. So I would probably say to wait as well, especially if they're not having any issue, like pressing issues now.
Yeah. I think we all agree with that. So. This is a 60-year-old individual, 60-year-old female, and for the last 3 months, she seems to get bloody noses a lot, 2 or 3 times a week, usually in the evening. I was able to stop the bleeding by laying down and pressing a tissue on my nostril. Any suggestions as to what might cause this? Could it be related to the dry, windy weather? Makayla, what are your thoughts?
I definitely could be. And it kind of depends, like not knowing their history, sometimes like people on blood thinners and things like that can definitely bleed a lot easier if you're on any of those medications. I think one thing that I've kind of learned from ENT is there's like the saline gel that can be better than the saline spray. Using that in the nose can really help provide better moisture for those types of situations. So definitely could be, and I think, it's definitely bothersome to have that happen.
It is, right, yeah. And you wonder, if the person has been using a nasal steroid, if they do struggle with allergies, sometimes using Afrin
should just be taken off the market.
I know, don't have it on the shelf.
Medicine.
It causes so many problems. So wanting to know, is there something else that could be causing some thinning of the tissue there and making it more likely? But I would say if it's persistent and keeps happening, like you said, using kind of a gel or a saline spray to add some lubrication. I'm a big fan of some Vaseline inside the nose, so just very cheap, just a little, get it in there and add that barrier could be helpful.
And if that doesn't work, go get someone to take a look inside. The other thing, a lot of these bloody noses are scratching at your nose. So I will tell people, trim your nails super short, maybe wear gloves at bedtime so you're not scratching your nose in the middle of the night, because a lot of nosebleeds happen for that. And then you get a scab and you scratch at the scab, it itches, and so try those things and then go get it checked out if it doesn't get better. So. This individual's grandson was diagnosed with peritonsillar abscess, but she's never heard of it. Can we explain what it is? Makayla, peritonsillar abscess.
So, tonsils are kind of in the back of your throat, so an abscess is like a collection of pus or fluid, and it's usually on one side, and like you can get the voice changes, it kind of maybe feels a little bit like strep with like a sore throat and things like that. When we look, it usually like one tonsil, you can see one side's like kind of bigger, like unilateral swelling, and it is something that, happens not infrequently. So sometimes can do antibiotics, sometimes if it's really bad, have to have, ENT or someone drain it, but so it's essentially like kind of a collection of like pus or, infection in the throat.
In the back.
Can
actually be quite serious, so definitely want to get that taken care of. And like you said, if antibiotics sometimes don't work, the best treatment is just to drain it. And they can do that even in the ER. You don't always have to be hospitalized for something like this, but want to get that pus and fluid out and relieve the pressure that's happening back there.
If I remember my history correctly, that is what killed George Washington.
Oh, I did not know that.
I could be wrong about that, but there's a little niggle in the back of my head that says that. So it is potentially very serious. Medicine is a little different now than it was in 1781 or whatever it was. So here is someone who wants to know, is taking magnesium hard on the kidneys? Jen?
I mean, you want to make sure you're taking it within safe, reasonable amounts. And so if also question, why are we taking magnesium? I think there needs to be a good reason. If it's, I know neurology uses it a fair bit for headache prevention. If somebody is just low in magnesium, then they should be taking it. But if somebody has shown a need, I would make sure that we're following the instructions either from the prescription if it's coming from a provider, which is just obviously safer, then we can make sure that the levels aren't getting too high if we're supplementing. But if we're going to use an over-the-counter, I would say follow the instructions on the bottle. Don't go above and beyond that.
Anything to add?
Yeah, I feel like I recommend magnesium a lot for like headaches, sleep, kind of muscle
cramps.
Like the restless legs type of thing. And I would say that, if you're following the directions that your doctor is giving you and you have like normal functioning kidneys, that's the main thing. We get more concerned when like if you have CKD or like your kidneys are not functioning as well, just because you're not able to kind of filter out the excess if there is. But if you have normal functioning kidneys, I think magnesium could be helpful for a lot of different things.
Yeah, absolutely. This individual says that she is nervous about cleaning the ears of her 1-year-old. He moves around a lot and she's afraid the Q-tip might poke his eardrum. What do you recommend for cleaning a baby and toddler ears? Jen? Don't do it. That's what we recommend. Don't do it.
There's no need. There is no need. The ear can essentially clean itself. If there's some I would say, a washcloth over your finger, you really can't get that too deep in there. But I just think there's no need. I think just let it be. Yeah.
You're going to just push that wax in deeper, even if they don't wiggle. And I've seen a lot of kids with ear trauma because
perforated. Those eardrums get ruptured, and especially in a little baby. Things are tiny.
Just your finger around there.
Yeah,
anything you'd add?
No need to clean. I tell parents the only time I really need to remove wax is if I'm looking for an ear infection and I can't see their eardrum, and then we use a tool to get it out. But otherwise, you don't really need to be doing it at home. The only reason we need to remove it is to see the eardrum for an infection if that's a concern. But
absolutely. Yep. Vitamin K is an essential vitamin that allows our bodies to appropriately clot and stop bleeding. Dr. Paula Marsland is a pediatrician at Monument Health Spearfish Clinic and spoke to the Prairie Doc about the importance of the vitamin K shot for newborns.
Dr. Marsland says newborns are born with very low vitamin K levels.
What we realized over time was that a lot of infants were dying because of catastrophic brain bleeds. And the way we can prevent that is by giving them vitamin K shortly after they're born. And since we started doing that, we have taken the risk from 1 in 14 to 25,000 kids down to less than 1 per 100,000 with the vitamin K shot. So that's why we do it. It's that important.
The shot is administered 1 to 3 hours after birth.
This does not have to happen immediately as soon as baby is born, usually hours 1 to 3. And it's a shot that's given into the thigh, and that's it. It's one and done. And that's why we do it, though. It is because we know the risk of a bleed, and we know that those bleeds can be so severe. I often hear parents bring up that they don't want their baby's first hour to have something so painful happen, and that just seems wrong. And I love that heart that's so precious and so important that you're already advocating for your baby. And of course, we don't want to cause undue pain. I would also say, though, your infant just went through a vaginal delivery or even a cesarean delivery. They just went through the biggest thing ever. They're going to be okay. The shot is quick, and it's not one that has to go deep into the leg. It's given in the thigh, and it's fast and done. And usually just a little skin to skin, some nursing afterwards, bottle if your baby's formula fed, is all it takes, and there's no further complications.
So Makayla, what do we worry about vitamin K deficiency bleeding doing to a newborn?
So the main concern is like the intraventricular hemorrhage in newborns. They can bleed in their brain, which is pretty serious. So that's what we worry about with newborns, and it can just happen spontaneously without trauma. So that's kind of the concern, and vitamin K helps prevent that by replacing that with the shot, with the clotting. Yeah.
And why are babies deficient? Why don't they have vitamin K?
Their bodies just aren't able to produce it yet, and so it does take a number of months for them to develop that capability, essentially, and they're not getting it from their mother through the placenta. So it's just important to supplement from the very beginning. They just need a little more time to develop that ability to produce the vitamin K. But getting it from food is where, they would get it, eventually, but babies don't eat solid food until usually around 6 months. So,
yeah. And it doesn't get into breast milk, and it doesn't get across the placenta, and all of us, it's the bacteria in our gut that's producing the vitamin K for us, or what we're not getting from our food is coming from that bacteria, and babies don't have that either yet. Yeah. So they're really they need it. They need it. They need that vitamin K. Yeah. So, excellent. All right, let's get to more questions here. We have a lady from Esteline who would like us to talk about Meniere's disease. What is it? What causes it? What are the symptoms? And what treatments are available? Makayla, do you want to start that one out?
It's an inner ear issue,
And it's miserable.
Yeah, and it can be, it can be kind of tricky too, because you have like vertigo and different things. So sometimes it kind of is one of those things. It's kind of a process of elimination, right? You kind of have to rule out some other things before you get to that. There is some treatment options for it, but I feel like none of them are probably super great. But it can be really frustrating for people. Yeah.
What would you add?
I think that's where it's we kind of go with what is the more common diagnosis that would be, and vertigo would be one of those. A lot of patients will come in with ringing in their ears, we call it tinnitus. That can be just from exposure to loud noises over periods of time, years. But to get to Meniere's disease, often, we're going to try treating for vertigo. There's some medications that could be used, some physical therapy, and we can do maneuvers in the office that can help with that particular issue. But I would say if none of that's working, then we start the next step, and we may get to that diagnosis. But sometimes ENT is needing to jump in and be helpful because we're not always sure what's happening, and so asking for some help from a specialist is sometimes where we need to go.
Meniere's can be really incapacitating for people. It can, this very severe dizziness, vertigo, the spinning, vomiting, and a lot of times one of the big clues for the Meniere's is that ringing in the ear that's worse when you have these spells, and a lot of times Meniere's is kind of episodic for people, and there are some treatments, and again, like you say, in my experience, nothing works great. Sometimes it's just keeping you comfortable until that episode passes. This caller asks, what are the dangers when having a surgical procedure and going off of warfarin or being bridged instead? That is a good question. It's, as is so many things in medicine, it kind of depends.
Kind of depends why we're on warfarin to begin with, right?
First off, obviously this is a question that makes perfect sense to us, and it obviously makes perfect sense to our caller. But Makayla, first off, what is warfarin?
So warfarin is a blood thinner, so it thins the blood. Lots of times people are on it if they've had a blood clot in their leg or lung in the past. If they have some an abnormal heart rhythm called atrial fibrillation, it can be used for that. Sometimes if they have clots secondary to cancer, so any kind of situation where their blood is more likely to clot.
Or if they have an artificial heart valve is another big one. And interestingly, how does warfarin work? What does warfarin do? This vitamin K. Here we come. We just had a conversation about that. Warfarin is rat poison.
Yeah.
Warfarin is rat poison, and it works by blocking that vitamin K so that I don't have it to help my blood clot. But we've got to watch very closely when someone's on warfarin to make sure that their blood doesn't get too thin. And this is all relates to the same process that's going on with those little babies when they're first born. So it's a very pertinent observation question. Nice connection. So warfarin, we might use it for a variety of different reasons, and then why would we stop it?
So if you're having a surgical procedure, obviously we want to make your blood not as thin, right? Like we want you to be able to kind of prevent having excessive bleeding during the procedures. So that's where like Lovenox or some of like that has a shorter kind of time that it acts for. So that's why a lot of times they'll switch to like Lovenox, or sometimes in the hospital use like a heparin drip, just because it's a little bit easier to like turn on and off essentially. So I mean, there's obviously risks with that. Like I said, depends what you're on it for, but blood clotting and clotting where we don't want it is the major risk with kind of that transition and things like that. But that's why we have things like Lovenox that kind of help bridge through those procedures.
And that's why we call it bridging. So what that means is that we will switch from warfarin, which takes a while to get out of your system, and let your blood go back to normal. So we will stop the warfarin and watch your blood, and then we'll start something that we can stop that will not last as long, and so we can have your blood thin enough for as much time as possible, but then be able to have your blood be thick enough quickly for your surgery, and then go back to whatever you need. So what would you add?
I mean, I think super important when you're on a medicine like warfarin to make sure that you have that pre-op clearance done well enough in advance, trying to do that pre-op physical 3 days before your surgery. Not a great idea. Want to make sure that we've done that at least a couple weeks in advance so that we can figure out, what's the plan, and make sure people are really clear about it. Because you just have to find that sweet spot, I think, with the blood. It's not too thin that we're going to bleed during surgery, but also not too thick that we clot. So
in places we don't want you to clot. And what else might we want to be thinking about for a pre-op physical that makes it a really bad idea for you to say, oh, gee, I'm having surgery next week. Can you get me in today on Friday, Doc? Makayla, what other medicines specifically might you be thinking that this person, we need to adjust that before their surgery?
I mean, sometimes, like NSAIDs can cause vitamins. I mean, there's lots of, depends what you're on. If you're on diabetes medications, so like insulin and things like that, because obviously you'll have a period of like not eating where we need to adjust your diabetic meds. So there's lots of different medications that could be, or blood pressure medications, lots of times you hold for like a day, the morning of, things like that. Lots of times they want some blood work done too, for anesthesia to make sure that kidney function and things like that are okay. So, and sometimes with that blood thinner, there needs to be discussion between the specialist, if there's a cardiologist, hematologist, there needs to be some discussion sometimes had between those doctors on the plan for period prior to surgery.
Good for surgery with your cardiologist and your family practice doctor. The other medicine, because we're seeing such a large uptake of it, are those GLP-1s, the Ozempic, the Mounjaro, just those medications. And some surgeons are and I think it's more of the anesthesia side, but they want those medicines stopped about 2 weeks before, I've been noticing. So that's where we really need to get those pre-ops done with enough time so that we can say, okay, we are not going to be taking that shot tomorrow or the next Wednesday, Thursday, and then we can have the surgery.
And sometimes people are on biologics, for example, for maybe psoriasis or rheumatoid arthritis, and those may need to be, that surgery may need to be timed very carefully around those shots, and those shots may only be every 3 months. So it's something you got to think about ahead of time, not at the last minute. And we've got a lot more questions, and I love it, but that means I need to stop talking so much. Okay, so this person wants to know, is a heart rate of 55 concerning for someone who is 75 years old, a male? Makayla.
I think it kind of depends on if they're having symptoms, how they're doing with that heart rate. I mean, it is technically a little bit low, right? But some people, especially if they are very like cardiovascular, like exercise a lot and things like that, that may be just fine for them. And for someone else, they may not feel well with that heart rate. So I think it kind of depends on the symptoms. And if you're doing just fine with that heart rate without any symptoms, then that's probably just fine. If you're not feeling great with a heart rate of 55, then that's probably something you want to get looked at.
Yeah.
And it may be something we're doing to you.
Right. Yeah, you may be on a medicine.
You may be on something.
Lowering your heart rate.
Here is someone who said that they've heard of research saying that some protein products, I assume this is like protein supplements, protein powders, being high in lead. Can we speak to the use of protein products, the frequency, the need, those kinds of things? What do you guys tell your patients about protein supplements?
I feel like I've seen more with like kidney function impacts with like the creatine and things, not so much lead. It can kind of like falsely elevate some of your kidney tests, and then we get concerned that something's going on with your kidneys. And if you stop it, then your kidney function usually kind of trends back towards normal. I think for protein, the best is to try and get it from actual food instead of supplements. I understand some people, especially elderly and things like that, might need to look at supplements more, but I think for most people, trying to focus on getting protein in your food, in your diet, is the best way, because that doesn't kind of impact your kidney function or other numbers.
Absolutely.
Yeah. And I think that can be true for all supplements. I mean, if you don't have to take every single vitamin and mineral under the sun, it's also super expensive for people. So I think if we can just get our vitamins and minerals and protein through diet, it's just better.
Eat your food. Eat your nutrients.
That's right.
Eat your nutrients. Here's someone from Alcaster wondering what could cause continuous sinus drainage in a 70-year-old male. Oh, what a frustrating problem.
Yeah.
Jen.
I mean, I would wonder if maybe there are some polyps, just some little, usually benign tumors up high in there that's just causing some irritation. That is something that I would think of. Living in a rural area, is there just an allergic component? I mean, the harvest is happening, ragweed season. I mean, it could just be irritative, an allergic sinus. And so that could cause persistent drainage. I mean, I think in this case, I would say, well, let's first try an allergy medication. And if that still is not making any improvements, that's where I would say maybe we should get that looked at. And usually that would be more of an ENT, somebody that could actually, with a camera, look higher up into those nasal passages and see if there's something else going on.
Anything to add?
Yeah, like the allergy medications, sometimes like a steroid nasal spray can kind of help if there's something inflamed in there, kind of shrink it down and help a little bit that way. And then if you're not getting better with like good consistent use of that, sometimes the sinus rinses too can really help flush things out if you feel like there's a lot of drainage and congestion going on. But then like ENT, or sometimes you can do a CT scan of the sinuses to see if there's the polyps, a deviated septum, some kind of like abnormality, anatomical thing that's causing problems.
Reflux is another frequent cause of
and I
that.
think people, it's just one of those.
And it's a frustrating.
I'm talking about this,
Yes.
and you're saying it's this, and it's confusing. But absolutely, it can do that.
And it's a frustrating and very common problem. This individual wants to know, do older folks have more issues with digestion and bowel, like diarrhea and constipation? Jen?
Yes.
Nothing works quite as well as you get older. Gosh darn it.
No. My grandpa, he's passed away, so I can say, I mean, that was the biggest part of the day, was having a bowel movement. And so I'm not going to embarrass him, he's not here. But it was so challenging. And I would say for many older patients, constipation seems to be what I am seeing in my practice more than diarrhea. But it can make people so uncomfortable and bloated and just make people feel tired and not good. So I do think as we age, our GI system just does not work as efficiently as maybe it once did. So.
And the muscles get weaker, and it just causes all kinds of problems.
Yes.
So I feel like typically not as physically active, so you're not like up walking around as much.
And maybe not
typically not drinking
well.
as much water and things like that. So just kind of multiple changes that kind of lead to that.
Kind of go along. Dr. Mandy Greenway is a dermatologist at Avera Medical Group Dermatology in Mitchell. She spoke to Prairie Doc about psoriasis, why it occurs, and how biologics are being used to treat it.
So psoriasis is a autoinflammatory condition, which some people consider an autoimmune condition, which means that our body decides to start attacking a specific part of our skin, and that causes skin inflammation and redness and scaling. And it also makes the skin cells reproduce or turn over much faster than they normally do. And so that's why you can see people with psoriasis have like the really thick skin on their elbows and their knees. It's because our skin cells are turning over about 17 times faster than normal.
Dr. Greenway says there are multiple ways of treating psoriasis, one of them being biologics.
Biologics are a class of medications. They're kind of complex molecules produced from living cells, such as like proteins or antibodies, and they work by targeting a specific proteins or pathways within our immune system. That is very different from how traditional immunosuppressants or traditional treatments work, where it actually kind of suppresses the entire immune system by interfering with cell proliferation, so cell turnover and cell function and cell growth. And so we're looking at targeting a specific portion versus turning the entire immune system down.
Plaque psoriasis is a condition where biologics work the best.
But it also does work for other types of psoriasis, including guttate psoriasis, which is a type of psoriasis where it's a whole bunch of little spots of psoriasis, as well as we can have psoriasis in our folds, so in our armpits and our groin. And so they do work for all different types, but sometimes it's easier to get them covered with insurance for one type or another.
It is so amazing the things that those dermatologists can do with psoriasis. It's just a whole new world now than it was when I started this. But we've got lots of questions, and I love it. Keep calling. Give me more questions. We'll get to as many as we can. This individual from Facebook was wondering, what's a home remedy for excess earwax? Makayla, what do you tell patients about earwax?
Usually the Debra ear drops, because that's very minimally invasive. You can buy them over the counter. You kind of put them in and let them sit there, and then that just kind of softens it so it can kind of work its way out. That's what I usually recommend, especially if patients come in to the clinic to get their ears flushed and we can't get it all out, or sometimes it's been in there for a long time. It's kind of hard and packed in there. That's what I recommend, is doing that. It takes a little bit longer. You have to have some patience, right? It's not like an instant gratification, but that's what I would recommend.
And baby oil, olive oil, same thing, just to soften that earwax so that self-cleaning mechanism can do its job, and don't push it back in.
That's right.
Here's someone from Yankton. What can be done about bone spurs and arthritis in the neck? Such a difficult problem.
That's a hard one.
Especially in the neck, I feel like that's
I know.
just a trickier spot.
Yeah. One thing, anytime I hear a patient coming in with neck problems and there's some arthritis in there, I really try and shy them away from doing chiropractic treatments and manipulations of the neck. I've seen too many patients come back with some complications from that. And so, I think with any type of arthritis, it's a bugger to deal with because it doesn't get better as we get older. And so we try and just use those supportive mechanisms of, if you can safely take anti-inflammatories, your ibuprofen, your Aleve, that can be helpful. Heat can be very helpful for people. I think within the neck, making sure that your shoulders are strong, your back is strong, so those supporting muscles, so physical therapy can be very helpful.
Sometimes injections can be helpful.
If it's severe enough, absolutely. Just directly get into where that problem is and reduce inflammation.
And I think sometimes the chiropractors will use their little clickers. And that's safer.
That's safe. Yep. Absolutely.
Just
no cranking of the
cranking
neck.
on the neck.
Or sometimes topicals I do, because sometimes if people are older, they can't necessarily do the orals, but they have, the Biofreeze, the Voltaren gel, things like that is sometimes a nice option for people, because they can do it a couple times a day.
Much safer.
This individual is wondering what could cause excessive saliva. It appears thicker and more stringy than regular saliva. What are your thoughts?
Interesting.
Jen.
Yeah. I'm like, that's an interesting question. I mean, I would first look at diet, kind of what are we eating and drinking?
Are we drinking enough?
Yeah. Is there, I mean, because sticky, thick saliva makes me think maybe somebody's dehydrated. We look for kind of tackiness in the mouth, and so that could be just a sign of dehydration. Making sure that there's not something orally going on, any sort of infection, maybe a fungal infection on the tongue. I think that's kind of where I would start with
The other
oral
thing I always
exam.
think about with excessive saliva, that water brash, I mean, is this someone who's really having reflux that may be silent? You may not feel it as heartburn, but it can irritate those tissues and cause that. So if drinking more water doesn't fix it, go see your doctor. Oh, this is a tough one. This is someone who is wondering if there are any ways to regain taste and smell after several years of losing those senses since COVID. And that's one of those COVID,
This is tricky.
Makayla.
I've seen some different, approaches to it. Sometimes trying an antibiotic treating a sinusitis or something like that can be helpful. I've seen steroids used to try and decrease any inflammation, or kind of the scent training, I think it's called. Kind of re-exposing yourself to some of those stronger smells to kind of retrain your body in a way. So I think there's a couple different approaches to it, and then I don't know if there's one good one, but it's kind of just trial of a couple different things to see if you can get some improvement in it.
I think some of that kind of the retraining, and so whether it's being done through, I don't know if it's occupational therapy or speech therapy, but there does seem to be weak evidence. I mean, I just think that it's one of those really hard kind of post-COVID complications, and we'll see this sometimes in people that have been through chemotherapy treatments, and so I
those
think
nerves are damaged, and those nerves don't always come back very well, irregardless of what damaged them. Oh, what are causes of severe burning mouth syndrome?
Oh,
that's another frustrating part. We're getting all kinds
these
of
I know, and I feel bad for those that are asking, because that means they might be suffering from it. Burning mouth syndrome that's a hard one.
So what is burning mouth syndrome?
I mean, I had to learn about this because I didn't know. This wasn't something I learned in med school or residency, and so now in my mind I think of it as kind of a fibromyalgia in the mouth, and so really have to be careful with trigger foods, so foods and drinks that can make that worse. It's just often chronic, debilitating. It's very painful for people. Have to make sure you've seen a dentist, make sure that there's nothing physically wrong in the mouth that can be taken care
Check
of.
your vitamin B12 levels, some of those things. It's another nerve abnormality that nerve is just sending that pain message. And
that's one of the treatments is kind of a nerve pain medication, gabapentin or amitriptyline, and those are same meds that we would use for fibromyalgia. I have patients that use a lidocaine, kind of a magic mouthwash, just to numb the mouth, but it's such a short-lived treatment. I mean, it gives you some relief for a little bit, and then the symptoms can come right back.
It's a very frustrating, difficult problem.
It is.
This individual has small bumps on the top of both hands and partway up both arms and on their forehead. What causes them?
I feel like that's really tricky without pictures. Dermatology is hard without seeing it.
That is a boy. It could be an encyclopedia worth of things. It could be just needing more exfoliation. It could be psoriasis. It could be any of a number of things. Go see someone that can actually see those bumps. Help you there. Ooh, here's a good one. The Inspire device for sleep apnea. What is the effectiveness, and would we recommend it? Makayla.
I haven't had a lot of people that I've seen with it, I guess. CPAP is the traditional treatment for sleep apnea, and I think lots of times the sleep medicine physicians and people that are managing it are really push that, and I don't know. I guess I don't know insurance coverage. It is a newer thing as well. I haven't, like I said, I haven't had a lot of people that I've seen with it or actually have it placed. Or I'm not sure if you guys have.
I haven't either. Like you said, I think CPAP is really where we would want people to move towards when they've got sleep apnea and we're trying to treat it. I have had a couple patients that they just could not tolerate the mask, and they've had a lot of night tears and tearing at things, and they just wouldn't leave. I mean, we found the mask that was comfortable for them, but still they would not leave it on. They've gotten the Inspire device, but insurance coverage is hard. I mean, so it took quite a while to get that approved. They're having success, so my N of 2. I mean, but it's just
not everybody with sleep apnea is a candidate.
Yep.
It's not just that you can't tolerate the CPAP or won't tolerate the CPAP. The collapse in the airway has to be in the right place. There's a lot of fine points. Yeah. So I would only do it if somebody absolutely positively would not, could not do CPAP. And even then, it may not be an option for you. So work harder at your CPAP.
That's right.
Which is not always easy for people. There are some people that it's just not going to happen for. But all right, this female, has had an earache and sore throat for 2 weeks, doesn't have a fever, had her ears washed out by a doctor, and the ache has become more prominent since then. Better in the morning, hurts more in the evening. What causes earaches?
Lots of times it's fluid behind the ears, I feel like, especially if people have had an upper respiratory, they just have that pressure sensation. Sometimes it can be the canal. You can get kind of like an external kind of inflammation, irritation too. So
which I'd wonder about if this person just had their ears washed out.
Yeah. So
sometimes dental infections, you'll get that referred pain up into the ear, and the ear may actually look okay, but look at that, there's something in the mouth. So
or the
TMJ. That can cause a really bad earache as well.
So lots of possibilities. If it persists, go in and get it checked out again.
And one thing I would say is if a doctor had looked at it, I often tell patients, try and go back to the same doctor if you can. The second opinion often doesn't lead to what you want, because it's, okay, we've tried this first, you're still not better, let's try this now. And so that continuity, I think, is really important.
And just I saw this before, and hey, this looks a little different. I don't remember everybody's ears, but it's more helpful sometimes than reading the note. Here's someone from Gary, South Dakota. Left knee 78L stem replacement. I assume that must be some kind of description of the prosthetic that was used because of arthritis and other issues 7 years ago, now having bad arthritis again. Should the stem cells last longer, and what causes arthritis? So we're not really doing much stem cell in arthritis treatment. I know that was kind of a phase for a while, but I don't think that it's standard of care at this point. So if I'm right about that, then it's actually impressive to me that they got relief from it at all. If it's a actual prosthetic, then when I was in med school, at least they always said usually you could expect maybe 10 years.
Is what I heard too.
Is that still what they're...
that's kind of, because they prefer to do those replacements when people are older, right? Like they try to push off the surgery kind of as long as possible so that that prosthetic can last as long as possible.
So arthritis is usually wear and tear causing that, and maybe this... I had one gal with a hip replacement wanting to start jogging again, and that's maybe not the best idea. So maybe this person was jogging. Go back to see your orthopod again. Here's someone who, I think this, why the tip of their tongue hurts when he eats or drinks. We kind of dealt with a lot of that with the burning mouth thing. This person was diagnosed with gastroparesis after 7 months of not feeling well. By that time, she was down to 107 pounds from an original 160 pounds. Oh, such a hard problem. Was told not to eat foods with fiber, bone broth, pudding, jello, soft fruits and vegetables, baby food. Can this person recover? What is the recovery possibility with gastroparesis, Jen?
I think it's maybe not aiming for 160 pounds, but that's a very significant weight loss. And so I think we have to hope that there could be some improvement. Full recovery, probably not likely, but that dietary modification, trying to find those things that don't make you feel worse. Working, I think, really close collaboration with a dietitian would be really helpful.
And gastroparesis can be caused by different things, and they may have different prognosis for how it might
have started, or what was the trigger for it.
And boy, we've still got, let's get as many as we can here. Somebody wants to know how to prevent dry skin as we move into winter.
Ooh.
Makayla.
I think using the lotions or creams that come in like the jar and are really thick, those are much better than like the pump
greasy,
ones. So like your Aquaphor or like the things that are really greasy and thick, and kind of putting it on, and then like before bedtime, if you can put like long sleeves on, long pants on, I think that's like kind of the best way. And doing it frequently, like after every shower, and being consistent about it.
And on the shower side, I love hot showers, and so that is a big no-no when you've got dry skin, and it's hard in the winter. It's cold.
Because it's cold.
I want hot water, but it can be so drying. So a moderately warm shower, and then that nice thick greasy. I think that's the best. Yeah.
We have a caller from Mitchell. It's diabetic on Mounjaro. Is that a good medicine, or are there risks?
Both?
Yes.
True.
I
think,
I have seen Mounjaro and medicines like Mounjaro, Ozempic, just make a huge, people that had been on high doses of insulin getting off their insulin with the Mounjaro.
Same.
But
there are risks.
With anything.
Yes.
What are some of the risks of, we've got like 45 seconds yet.
I had a patient who almost lost too much weight. Like she was kind of, like we were doing it for diabetes management, and she lost too much weight, so we had to like back down to one of the lower doses. The GI side effects can be really difficult.
Like gastroparesis.
Because that can be really difficult for people. They don't really they can have difficulty tolerating it.
Pancreatitis, it can, and sometimes it doesn't go away when you stop the medicine. But diabetes can do those things too, and everything is a balance between the risks and the benefits. So this has gone so fast, ladies. Thank you so much for joining us tonight. Our winner tonight is Dennis. A book will be sent to you shortly, and we'll be back after this.
Hi, my name is Joni Holm, and I serve on the Healing Words Foundation board, the nonprofit that runs the Prairie Doc programming. Our mission is to enhance health and diminish suffering by communicating useful science-based information respectfully and compassionately. Your donation supporting Prairie Doc programming makes an extraordinary difference. Gifts of any size enhance its impact in our state and beyond. Thank you for your generosity.
Feeling overwhelmed by the amount of health information lately? Unsure of which sources to rely on? Visit the Prairie Doc YouTube channel today to catch up on all past episodes of On Call with the Prairie Doc. And don't forget to join us most Thursdays on SDPB, YouTube, or stream our episodes live on the Prairie Doc Facebook page.
As we finish up this evening's discussion, I want to thank Dr. Tinguely and Dr. Bretschneider for sharing their expertise with our viewers. And thank you to all of our viewers for tuning in tonight. We appreciate your continued viewership and support of our mission. Don't forget to follow us on Facebook, Instagram, YouTube, and TikTok for more information and updates. If you missed sending in a question tonight, send your questions to ask@prairiedoc.org to be answered on our weekly radio program, Prairie Doc Radio, Sundays at 6 a.m. and 1 p.m. on South Dakota Public Broadcasting Radio. And be sure to download and subscribe to the podcast version of this show and Prairie Doc Radio, wherever podcasts can be found. Thank you for joining us for another On Call with the Prairie Doc. Until next time, as our founder, Dr. Holm, would say, stay healthy out there, people.
Vaccination is a vital public health tool that protects individuals and communities from preventable diseases. It's crucial to understand the science behind vaccines. Immunity matters, the importance of vaccination. Next time on Call with the Prairie Doc. Major funding for On Call with the Prairie Doc has been provided by...
At Avera, our nationally recognized health system will be right here with you, with care and coverage. Hello possibility. Hello healthy. Hello life. Avera, moving health forward.
Larson Manufacturing is proud to support On Call with the Prairie Doc as it continues to open doors for important medical information. And with the ongoing support of these individuals and institutions: Brookings Health System, South Dakota Academy of Family Physicians, Sanford Health, Avera Medical Group Brookings, Avera Heart Hospital, First Bank and Trust, Dakota Allergy and Asthma, Monument Health,